Hello, ladies and gentlemen. Good afternoon. Or if you are listening to this in the evening hours, good evening to you. Today we are talking about community nursing and all of the different types of nursing that go on out there in the community. There is a lot more community nursing opportunities than one might think. And more and more companies, more and more facilities are beginning to use nurses in many, several, and different types of roles. So this opens up a lot of doors for us in the community as nursing professionals. So the outcomes for this class are to apply the concept of community and population to nursing care, determine how public health nursing is the foundation of community nursing. Public health nursing and community nursing, they are intertwined somewhat, but by the same token, they may wear very different hats. We will analyze the reasons for an increased need for nursing in community-based settings. We will talk about the importance of culturally competent care, because this is very, very important. In a hospital setting, we have many resources at our disposal. In someone's home, we also have resources. They may be different resources, but we also may have no resources at our disposal. But because we are actually in the client's home, we need to respect their ways and their beliefs and their culture. And we will talk about contrasting and comparing home health care and hospice care, because they are two totally different aspects of nursing. So, why are we doing this? Why are we talking about this? Well, the United States population is aging rapidly. Even with COVID, yes, we are still aging, thank goodness, and the number of older adults is expected to double by 2050. So, as you know, because of insurance purposes, hospital stays have become shorter in an effort to reduce healthcare costs for the insurance company, for the individual, for the hospital. So, as a result, community-based healthcare, including home care, is rapidly expanding. It is a very, very growing field. So why? Why are we doing this? So community means gift or fellowship of common relations and feelings. So wherever we live, or wherever we work, or wherever we are going to school, that is our community. The notion of community suggests a general sense, selflessness, sharing, relationship, and doing good that comes from working together. We are all in this together, and if I know I'm so sorry, but if I have to hear that one more time, I'm going to scream. But yes, we are all in this together, meaning that we are all working through this nursing program together to get to that end goal. So most members of a community share a common language, certain rituals, and special customs. So common language, this could mean the home. This could also mean the medical field, because we do have a language and a jargon that is all our own. We do have rituals, and families certainly have rituals and traditions and customs that must be respected. So, population. Listen up, listen up, listen up. Population. Population is traditionally thought of as a certain geographic region inhabiting a specified area. However, it can also mean a group of people of a particular race or a class in a specified place. For example, there are approximately 1,500 Latino people living in Atlantic City. I don't really know if that is the true statistic. That is just a statistic that I found. But so in this respect, that is the population of the Latino people living in Atlantic City. Okay, so now we understand what population means. In reference to us, we are the nursing population of Atlantic Cape Community College. right? Because we are living in the nursing building, or we're trying to live in the nursing building. We would like to live in the nursing building again. It can also mean any group of people subject to statistics or other studies. For example, all of the homeless people living in Atlantic City, that is a population. Or all of the pregnant women living in Atlantic City, that is a population. When we talk in nursing, we can ask, what field are you in? Well, I'm in med-surg. Or we can also ask, what population do you deal with in your work? Well, in my work, I dealt with med-surg, yes, certainly, but I was also neurology and orthopedics. So that was the population that I dealt with. So the United States Bureau of the Census conducts a survey and count of the American people. And you will see this all over. You've gotten phone calls about the U.S. Census, and you see, advertisements for filling out the U.S. Census, and it's been on the radio, it's been on television. So the population of the United States will do this about every 10 years, and it was done in 2010. So now here we are in 2020, and that is why it needs to be done again. When the census is completed, the United States Bureau groups the data into sections of 1,500 to 8,000 people, and these are known as census tracts. Maps and census tracts show the geopolitical boundaries of a community. So when we're talking about maps and census tracts, that is mostly for politics, and I'm really not going to go down that road. But just know that the census is done every 10 years. It was done in 2010. We are now doing it in 2020. And the Bureau will group the data into sections from 1,500 people to 8,000 people. So an aggregate. An aggregate is a group of individuals with at least one shared characteristic, either personal or environmental. So we, in the nursing program, we all share the goal that we are looking to help you get through this nursing program, and you are nursing students. So in that way, we are an aggregate. Also, for example, a community health nurse may work with a class of high school girls to reduce the incidence of adolescent pregnancy. The shared characteristics of this aggregate are that they are female, they are of childbearing age, and that they attend a particular school. So, components of a community. Structure. Structure refers to the general characteristics of a community. Listen up, listen up. Structure. Structure will refer to the general characteristics of a community. So we have demographic data, which will include gender, age, ethnicity, education, and income levels. And then there will be data about healthcare services, which are the number of primary care workers or emergency care facilities that are within that area. So again, structure will refer to the general characteristics of a community. Status. Listen up, listen up, listen up. Status. Status is the biological, emotional, and social outcome components of a community. Biological, emotional, and social outcome. So biological data, we are talking about morbidity. Morbidity refers to illness, and then mortality. Mortality, of course, refers to death. So morbidity and mortality rates, life expectancy ratios, and risk factor profiles for the respective age groups within a community. That is all biological data. Emotional data are general indications of mental health and consumer satisfaction about various aspects of the community as compared with other locales. So emotional data is going to include mental health and consumer satisfaction. And then social data. So we are looking at crime rates, citizen involvement in community-wide activities, how active is the community, how involved are the people that live there, and general functioning levels of the community members. And this is all status, the biological, emotional, and social outcome components of a community. Process. Process describes the overall effectiveness level of a community. Do the members of the community perceive that they are part of a group with a common purpose, value, and interest? Are we all moving in the same direction? Do we all have the same goals? Do we all want the same thing for the place where we live or work? What is the extent of interaction among community members? You are always going to have community members that are more active within the community. They're very proactive. They're very involved. They want to make things better in the community. And then you have others that live in a community that, there are some things that they just don't care about. They don't give a hot damn, and no, they're not going to be so active. And so also, does the community have an established forum for conflict resolution? Now, on a larger scale community, I live in Egg Harbor Township. So on a larger scale community such as I live in, we are sometimes subdivided into smaller communities. But when we're looking at this, does the community have an established forum for conflict resolution? We are looking at even smaller populations. So this might be an over 55 community. This might be a senior housing community. This might be anywhere where people are living together, where they may be discontent, where they may be some conflict in the way people are taking care of their lawns or walking their dogs, and the dogs are peeing on the lawn. Do we have something to do with that? And how people maintain their homes. So is there an established forum for conflict resolution? Meaning, are there a group of people that I can take my complaints to, and they will help me to resolve this conflict? So, making a community healthy. When determining what makes a community healthy, listen up, listen up, listen up. In determining what makes a community healthy, the National Census paper, Healthy People 2020, will provide these useful guidelines. Right now, that is what we are looking at. We are looking at Healthy People 2020, and we have been looking at Healthy People 2020 for a number of years now, because when we did the census in 2010 and created those guidelines, we remember the census is done every 10 years, so now we are projecting. So after the census of 2020, then we may see Healthy People 2030. But right now, we are looking at Healthy People 2020 to provide those useful guidelines to tell me whether or not my community is a healthy community. So, Healthy People 2020 will identify leading indicators for measuring the health of our nation, and these examples will include physical activity, overweight and obesity, smokers and tobacco use, substance abuse, sexual behavior, mental health, injury and violence, environmental quality, are people up to date with their immunizations? And also, listen up, listen up, listen up. The most important one, the primary focus, is access to health care. And does this community have access to primary health care services and primary care services? Listen up. The one that we are going to look at and focus on and talk about is access to health care, access to primary care services. So, the overachieving goals, there are 4 overachieving goals of Healthy People 2020, and these initiatives are to attain higher quality, longer lives, free of any preventable disease, disabilities, injury, and premature death. So we are going to look at goals and ways to have the people that inhabit my community live longer lives free of a disease that is preventable and leading to premature death. We are looking to achieve health equity, eliminate health disparities, and improve the health of all groups. So again, we are working to prevent disease. Create social and physical environments that promote good health for all. Social and physical environments, are there gathering places where people can gather and be social? Are there recreational clubs? Are there recreational activities in the community? Can they play tennis? Can they golf? Can they swim? Are there walking trails? Is there parks? Do they have playgrounds for children? Are there social and physical environments that can promote good health for all? And we are going to look to promote quality of life and a healthy development and healthy behaviors across all life stages. Because again, if you look back, we are talking about smokers and tobacco use. We're talking about obesity. We are talking about substance abuse. So we are looking to promote quality of life, healthy development, and healthy habits, healthy behaviors to keep everyone in the community healthy. So if everyone is healthy, well, then we have nothing to do, right? So in order to get everyone healthy, we have to look at those populations that is vulnerable. So a vulnerable population is an aggregate that is at an increased risk for adverse health outcomes, which means that they are at-risk individuals. Whether they are very young, they are very old, that is the most common vulnerable population. So we have to look for these people and identify them. Limited economic resources. Income is a major predictor of health risk. So many persons with low income will forego preventative care and seek health care only when they are very, very ill. And we understand this, right? We know this. We know this. We know that if people do not have access to affordable health care, if they think they have a cold, they're just going to wait it out. They're going to go to CVS or they're going to go to Walgreens and they're going to get some over-the-counter medications and they're just going to try and treat that and handle it and take care of it on their own without seeking out a medical professional. But what happens if it's not a cold? What happens if it's not a cold and it really is a virus? Well, true, virus still has to run its course, but a virus is a lot more difficult sometimes to battle, especially in this day and age of COVID, where we need medical personnel. UTIs, very, very common. I think starting with the urinary tract infection, I really can't go to the doctor. I don't want to go to the emergency room, so I'm just going to drink a little bit more cranberry juice. I'm going to, try water. I'm going to pee more often, and before we know it, all of our home remedies are not working, and instead of just a simple urinary tract infection that could be treated with antibiotics, we are now into a bladder infection and then kidney infection, which sometimes can be fatal in someone who is very young or in the elderly. Limited social resources. Friends and family are valuable resources to help a person deal with day-to-day stress and demands of an illness. Older adults who live alone and people with mental illness are examples of groups at risk because of social isolation. So, when you have friends and family around, people that you can share with, people that you can talk to, people that are looking at you, you're looking at them, and they're saying, well, yes, I think they're handling this well. No, they're really not handling it very, very, very well. Not that you need to know this, but I had lots of struggle last semester when we were shut down and we were isolating, and I'm trying to do my job from home, and I'm wondering if I'm being successful, and are the students understanding the information, and am I getting my point across, and am I doing everything that I can do? And so it was very stressful, but I was very, very lucky that I had friends who understood and that I could share these this stress with, who, sometimes just let me vent, other times gave me very valuable solutions. But they were very helpful in helping me to deal with the day-to-day stress of isolating and trying to do my job and not being able to do what I wanted to do when I wanted to do it, just like the rest of the world and the rest of the community. And then we have older adults who may not have family or friends looking into them. So, they are struggling to deal with whatever it is that they're dealing with, whatever minor illness that may turn into something more on their own. And then people with mental illness, sometimes there are people who will call and check in on them, make sure that they're doing okay. But oftentimes people who with mental illness are also pretty much on their own. So, more of what is making a population vulnerable. Extremes of age. So again, the very young and the very old are less able to adapt to physiological stress and are at an increased risk of disease. They are more prone to infections and may not be able to protect themselves against environmental hazards such as heat or cold. So it's been very, very hot lately. Do these people have access to air conditioning when it's so hot and humid and sticky, and maybe they're a respiratory patient and they don't have access to air conditioning and they're struggling to breathe? And then you have small children. So these age groups are also more often living in poverty. They are living below the poverty line. Chronic disease and obesity. People who have chronic diseases are at greater risk of health problems. For example, people with obesity are at an increased risk of heart disease, diabetes, impaired mobility, joint pain, and of course other complications. All of this is not new to you. This I know you understand. And then history of abuse or trauma. People who have experienced abuse or traumatic events often feel they have limited control over their health and circumstances. Abuse and trauma also stress a person's ability to cope, placing them at risk for physical and mental health problems. So again, do they have friends and family around them to help them deal with stressors, something that they're dealing with, if they've had some sort of trauma, or if they're struggling with a health issue or a mental health issue? Do they have someone looking in on them? Do they have someone that they can talk to? Is there someone that is a resource for them? Understanding the concept of community-based nursing. Community-based nursing. So community can either be a site for healthcare delivery, or it can be a recipient of healthcare services. So community-based care refers to healthcare or rehabilitative services performed in clinics, offices, mobile care units, and other facilities in the community rather than in acute care settings such as hospitals. So this is how we are going to define it. If you are in the hospital setting, and if you are in the hospital, you are a hospital-based nurse. You are a facility-based nurse. Once you gather up your equipment, whether it's a glucometer, a blood pressure cuff and a stethoscope, patient education materials, I can't really think of anything else right now. But if once you take those things and once you set up a table and a chair in the parking lot of your hospital, you are now community nursing. Anything that is done outside of the hospital setting, clinics, a medical office, a mobile care unit, facilities, other than in the hospital setting. So once you leave the hospital setting, you are now a community-based nurse. Understand? Community health nursing focuses on how the health of individuals, families, and groups affect the community as a whole. So when I'm in the hospital setting and I'm looking at my patient, I am looking at my patient. I may be looking at how my patient interacts with family members and whether or not it is safe to send my patient home because of the interactions with the other family members. But when I am a community health nurse, I am looking at individuals, I am looking at families, and then I am looking at the community as a whole. So the whole community now becomes my patient, so to speak. Community health nurses strive to promote, protect, preserve, and maintain the health of the population through the delivery of personal health services to individuals, families, and groups. So, it is true where I may be dealing with a couple of individuals that live in a certain community, or I may be dealing with select families that live in a community. But for the most part, again, I am looking at how these individuals affect the community as a whole. So if I notice that I am seeing a flare-up of, or an exacerbation of TB, for example, in this one section of my community, well, it's because, all of these people are intermingling and interacting with each other. So I have to address this small community or this small population that is experiencing this outbreak of TB, tuberculosis, so as to protect the rest of my community. Public health nursing. Listen up, listen up, listen up. Public health nursing focuses on the community as a whole and the eventual effect of the community's health status on the health of individuals, families, and groups. So, here we go. When I am a community-based nurse, I am looking at the community. I am looking at how the family impacts the community. The community is my patient, and I am looking at how this one particular family or this group of family is going to interact and affect the health of my community. In a public health setting, I am looking at what the community is doing or the effect the community is having on the health of individuals and families. So is there something going on in my community that is putting the rest of my healthy families at risk? So the goal of public health is to prevent individual disease and disability in addition to promoting and protecting the overall health of the community. So I have to protect the community at large. Yes, I do. But in the end, I am protecting the families that live in my community. So today's public health nurses will function in a health promotion role and possess skills such as community assessment, cultural competence, program planning, communication, financial planning and management, leadership, system thinking, and policy development. A public health nurse will wear many, many, many different hats in any given day, at any given time. So, and now is a good time to assess this and to talk about this, because we are talking about assessing a community as a whole. Just because we are out in the community, the nursing process does not go away. The nursing process in the nursing field never goes away. It will never leave you. So, when you are dealing with a problem in your community, you are going to assess that community and the effect of this impact on your community, whatever the health problem is. COVID, TB, measles, it doesn't matter. You are going to assess the impact that it is going to have on the community. Then you need to formulate a plan. What am I going to do? How am I going to isolate these people that are sick? Do they need to be isolated? Or what am I going to do to treat them? What are my interventions going to be so that I can keep the rest of my population safe and well and healthy? So then you're going to come up with a plan. You are going to come up with some outcomes. one of which will be I want to keep my community safe. Same way in a hospital setting, we want to keep our patients safe. And then we're going to implement those interventions. I am going to put into place and actually start working the plan that I have come up with. Now, in working the plan that I've come up with, I might have to reach out to schools. I might have to reach out to school nurses. I might have to reach out to politicians. I might have to reach out to business owners. Who knows what I have to reach out to in order to implement my plan. And then I am going to evaluate after a week, after 2 weeks. Is the rate of TB going down? Are people taking their medications? If it's measles, do I have less cases of measles? Are parents at home, and are they monitoring, and are they taking care of these children and not putting these children back in the school system so that they won't infect the other children? The nursing process will never go away. It never goes away. So, for example, a public health nurse may be employed by a county health department. So whenever, again, we're talking about public health nursing, this is somebody who works for the county. Some of them work for cities, like the city of Summers Point, the city of Ocean City. There might be a public health nurse, but these communities are very, very small. So there just might be one public health nurse for Atlanta County. So, but it is always a county position. So a public health nurse may be employed by a county health department to provide surveillance services to monitor for tuberculosis, which is TB. The nurse helps to protect the entire community by screening for TB at the local school, by testing high-risk individuals for TB, and by identifying and tracking clients with active disease to ensure that they complete the prescribed 6 to 9 month medication regimen. So again, somebody with TB, tracking clients is not new. I know some of you may have only just been hearing about it now because of COVID, but whenever there is an exacerbation of anything, TB, measles, the flu, anything like that, we always want to get to patient zero. We always want to get to, and then from there, we have to track. How many people have those people been in contact with, and then how many people have those people been in contact with? And that is the job of the public health nurse. I have to find all of these people that these individuals who are sick have come in contact with. And I also have to check and see the people that are already infected, are they being compliant with their medication regimen, right? Just like in the hospital setting, I have to look and I have to constantly reassess. Are you taking your meds? Are you being compliant with your meds? And then, is the medication working? So because public health focuses on large-scale programs for the entire community, government-based agencies often provide services. So the United States Public Health Service is an example of a public health agency within the federal government. So again, it is a county job, it is a government job. So some examples of successful health programs are human papillomavirus, HPV immunizations for adolescents, smoking cessation programs, motor vehicle and infant car seat instruction, and obesity prevention programs for children. These are all programs that within the last 10 years, according to Healthy People 2020, we have been successful with. So now, community-oriented nursing. We talked about public health nursing, where we are looking at individuals and families within the community, and then the impact of these individuals on the community. So community-oriented nursing combines components of community and then public health. So the focus is going to be on health promotion, illness prevention, early detection, and treatment provided within the community setting. So practice, of course, is evidence-based because we are professionals, we are nurses, and everything we do is evidence-based. And it is also collaborative with other community health disciples. So again, or disciplines, who do I have to reach out to in order to get my job done? Do I have to work with the school system? Do I have to work with a transportation company? Do I have to work with medical offices? Do I have to talk to people at urgent care? Who do I have to work with and speak to in order to get my job done? So the approach is a comprehensive look at the individual, family, group, and community at large. For example, a nurse in a community-oriented approach might work in an adolescent prenatal program. So the nurse is going to provide individual care at the local clinic 2 days a week, right? So at the clinic, she's going to gather data from adolescents about the schools they attend, as well as their knowledge of birth control, or maybe in this case, lack of knowledge of birth control, pregnancy, and childbirth. So now we have 3 days, right? Because she's only at the clinic for 2 days. So on the remaining 3 days, the nurse may meet with school officials to identify pregnant teens who need this prenatal care. Maybe we need to teach a class about sexuality in the local high school. Do we have to speak more about birth control? Do we have to talk about having access to birth control, such as if a teen is sexually active? I'm not going to stop him or her from being sexually active. I can try, but I'm not going to. So then my mindset has to go to, how do I keep this teenager safe? How do I keep her safe from sexually transmitted infections? How do I keep her safe from pregnancy? How do I keep her safe from anything that is going to harm her? Perhaps she is in an abusive relationship with her boyfriend. These are all things that we have to think about as community health nurses. And then we need to work with teachers to identify strategies to keep these pregnant teens in school, because we don't want to lose these students. Yes, they're going to be challenged and they are going to face many challenges, but the ultimate goal is to get them their education and, if possible, keep these teens in school. So as this community nurse, I am working very closely, even though I'm out in the community, I am working very closely with the school system. So here you can see the relationship of community nursing approaches. So whereas the public health nurse has the health of the community in her eyesight, that is her goal, keeping the community healthy. But the community health nursing is looking at the health of the individual, the health of a family, or the health of a group of people. And oftentimes, as you can see, yes, this is going to be intertwined. You understand? So there have been many pioneers in community nursing, just very briefly. So Florence Nightingale, she established the importance of promoting health by manipulating the environment with light, with warmth, sanitation. She was the first infection control nurse, and nursing the whole person. She was the first nurse to think about holistic nursing. My patient is a little depressed. Is it going to help him if I move him by the window and he gets to look out the window and see what's going on outside, and if he sees a bit of sunshine? Is his environment clean? Is he warm? Is he cold? Lillian Wald, known as the first community health nurse, founded the first Visiting Nurses Association in New York. She was the first nurse to go out and actually work in people's homes. Clara Burton, she was the founder of the American Red Cross. And Margaret Sanger. Margaret Sanger founded the International Planned Parenthood Federation, pioneering the use of family planning and birth control education, which is also, and again, everyone thinks that Planned Parenthood is just about, teenagers and, birth control, but no, Planned Parenthood will offer so much more, so much more. So working within communities, the community nurse's roles will vary depending on the community and its identified needs. Identified needs. And again, we have to identify these needs, right? And we are going to identify these needs by what? By performing an assessment, because we are nurses and we assess and then reassess. And one of the most effective nursing interventions that we can use when we are out in the community is empowerment. It is also one of the most valuable tools that we can use also with patients and families, empowerment. So assisting the client, whether that client is an individual or whether that client is a community at large, we will assist the client to recognize and use valuable resources to achieve or maintain the desired length of health, achieve autonomy, and maintain a positive self-esteem. Because once the community is healthy and once the community feels as though it is moving forward and the families in the community are healthy, they feel empowered to do better, as do patients. Once we put the choice of healthcare in their hands, you can either sit in the chair or you can go for a walk. But both of those things are going to help you breathe a little better, expand your lungs, lessen your risk for pneumonia. Well, I think I'm going to sit in the chair. I'll sit in the chair this morning, and then this afternoon I will go for a walk. They feel empowered. I am making this decision on my own, and I am feeling empowered by it. So, the roles of these community nurses. Client advocate. So the client advocate, the effective community health nurse consistently supports the identified or expressed concerns of the client and or the community. Just like in the hospital setting, where in the hospital setting you are a client-patient advocate. If your patient cannot speak for himself, you will take on that role and you will speak for him to protect him or express his concerns if they cannot do it themselves. You will do the same for these individuals or these families in the community, or if the community at large brings you an issue, you will speak for the community. So as a community health nurse, you can affect change by getting involved in your local Student Nurses Association, in professional nursing organizations, by working in the school board, citizen communities, if there's activities going on in the community that you live, and by attending council meetings, whether it be a council meeting for a school board or a council meeting for the township or the city in which you live. Educator. We are nurses, and one of the things that we do without fail, besides assess, is to educate. We are always going to educate. So, because community nursing focuses on wellness and disease prevention, much of what the nurse does will involve education. Education of the individual clients, groups of people at risk, politicians, or a community. So the most effective educational programs are concise, provide relevant, practical information, and they can be easily incorporated into the learner's daily routine. So when you are educating a community or when you are educating families within this community, you will take the same approach as you would as if you were doing patient education one-to-one in a room with your patient. You're going to talk about things that are relevant to them and also how they can incorporate these changes into their daily routine to make it a habit. Collaborator. Listen up, listen up, listen up. Collaborator. Collaborator. An example of a collaborator is when a community health nurse is concerned about poor compliance with recommended immunization schedules for 2-year-olds in her local community. Okay? So after talking with some of the parents, this nurse discovers that the client's operating hours are limited and that the automated call routing system is frustrating for people trying to set up an appointment. And we've all been there, right? When you call someplace, call the doctor's office, you're calling, I don't know, anywhere. You're a credit card company. You're calling Verizon. Oh my God, Verizon. I don't even want to go there. And, you have to practically jump through a hoop to get a live person, because one menu is going to direct you to another menu, which is going to direct you to another menu. Well, if you're trying to set up an appointment for your child, all of this can be very frustrating. You understand. So, and on top of that, the clinic does not offer online scheduling. So the nurse also discovers that the clinics do not email, they do not text reminders to these clients, nor does anybody follow up if an appointment is missed. Why did you miss your appointment? What kept you from coming? What prevented you from bringing your child? So the nurse has now assessed all of this, right? And in her assessment is the clinic's office hours are limited, the call routing system is frustrating, and the clinic does not offer online scheduling. There's no texting, there's no emailing to remind them of appointments, and if you miss your appointment, nobody seems to care. Nobody's following up. So the nurse assesses all of this, and when she gathers all of this information, now she has to make a plan. So what am I going to do? Well, I'm a collaborator, so I'm going to collaborate. I'm going to collaborate with other people to rectify this situation. So the nurse will schedule a meeting with the clinic staff, the practicing managers, and patients to resolve these issues. So she may reach out to people by phone, she may reach out to people by email. And then she is going to build a partnership, an affiliation that will address these concerns, and now we are going to work toward a resolution. So I've assessed the problem. These are all of the problems. And I've thought about what I can do. I've brought other people into the fold. How can we all address this? And then what can we do to fix it? So, in such a clinic, the appointment times fill up quickly. And most often, clients must wait more than a month or two for an appointment. Again, this is a concern. Maybe this is information that I got from patients or patient families when I called to reach out to them to say, why are you missing your appointments? Well, the appointment was made 2 months in advance, and quite frankly, I forgot about it. I thought it was on my calendar, but it wasn't. So before enrolling families in this program, you would need to be aware of these limitations and share this information with clients. And then also, you are going to make some other changes, such as following up with missed appointments, maybe texting a reminder to say, listen, your appointment is on Tuesday at 2, and, can you please confirm? So, but in doing all of this, the nurse needs to collaborate. She needs to collaborate with other people to get to why this is happening, and then what are we going to fix it. So then we have counselor. Once you have established rapport with the group, members may consult you about a variety of health-related and non-health related concerns. An example of this is when I was in my master's program, and I had to work in the community because my track was education, and I had to go out into the community and try and find a way to educate a population. And at the time, I was working at Shore, and I was on the neurology and orthopedic floor, and one of our initiatives was, stroke prevention, stroke protocols, getting people in quicker so that there was less deficit after a stroke, and in, lots of education about stroke. So what I did was I reached out to my community center in Egg Harbor Township, and the person there allowed me to come every other Monday. I went twice a month, every other Monday, and I was able to take blood pressures, and I handed out information about stroke protocol, and what to do if you suspect you're having a stroke, what to do if you suspect a family member is having a stroke, and I would do blood pressure screenings. So once I did that, and once I went a couple of times and they got to know me and trust me, my line was very long around the table, and it was very, very difficult because I only had so much time. I had an hour and a half before bingo started, and nothing gets in the way of bingo starting. And some people were frustrated, because of course their blood pressure had already been taken, they had already asked their question, and here, I still had people waiting. So I grew my program, And what I did was I went more than once every other week. I went more than twice a month to do blood pressure screenings, because that's really why I was there, and to offer education. But I also grew my program, and twice a month I conducted what I called roundtable discussions. So this is when they had the opportunity to bring a topic or bring a question or bring something to me that they wanted to talk about, and I was able to offer guidance or maybe some assistance and direct them to a resource where to go in order to handle the problem. But once you are working as a counselor, you need to be careful to offer counsel only within your scope of practice, and to make recommendations that are practical yet meet the needs of the community. Such as, is this something that you can talk to me about? Like, my blood pressure has been going up. And then when I say, well, are you under stress? What have you been eating? What have you been drinking? Well, it's been a holiday weekend and this is Monday and you're checking my blood pressure. And, I had a lot of salty foods over the weekend, and maybe I had a couple of beers, and, I think my ankles are swollen and my blood pressure is up just because I took in too much salt. But at least they understood that this was why. They took in a little too much sodium, and this is why. So I'm going to take my medicine. I'm going to, cut back on the salt, and that's going to meet my need to correct the problem. You may need only serve as a witness to the group's concerns. Sometimes they just want somebody to vent to. They just want somebody that they can sit down and piss and moan with, and then after that, yeah, I'm done. I'm fine with it. I talked about it, and now I'm done with the problem. And then allowing clients to discuss or work through issues empowers them. Again, there's that empowerment, and foster self-reliance. So once they know, for instance, once they understand, well, I took in a lot of salt, I took in a lot of sodium, and that's why my blood pressure is up, that empowers them to make better decisions, hopefully, the next time that a holiday rolls around. So, we are going to talk about how community nursing interventions are classified. So there are 3 basic levels of care in which nursing interventions can be classified: primary, secondary, and tertiary. So most community-oriented nursing practices are aimed at the primary, which is the prevention. The prevention level. Because remember, the community nurse is trying to prevent disease, encourage healthy habits and healthy behaviors. So, primary interventions. The goal of primary, which are first level interventions, is to promote health and prevent disease. Listen up. Primary, prevent disease. Both are P's. Primary, prevent disease. Primary, prevent disease. So primary interventions in order to prevent disease include education, collaborating. We may need to, if I'm a nurse, I may need to collaborate with the school system to prevent a pregnancy or prevent sexually transmitted infections, and civic involvement. Primary prevention. So if we're talking about education, education is directed at susceptible individuals with no known disease process. Meaning, they're relatively healthy, but I'm going to talk to them. I'm going to talk to them about smoking cessation. I'm going to talk to them about an exercise program. I'm going to talk to them about lowering salt in their diet. They are at risk for these diseases, but they are not yet sick. Same as you would in the hospital setting. You had somebody who was a new diabetic, but yet they don't have cardiac disease yet, and they don't have kidney disease involvement yet, but you're still going to educate them in order to manage their disease process because they're at risk for these other things, but they have not yet developed them. So, for example, a nurse may educate women of childbearing age to wear insect repellent when in a location where mosquitoes potentially will carry the Zika virus. Okay? They're pregnant and they are at risk, if they're around standing water or if they're going to travel. Not these days, of course, but that the mosquito is out there and that it can harm the baby. Collaborating. Again, there is that word collaboration, and we will collaborate with local agencies to provide clean and secure temporary housing for migrant farm workers. This is very, very important up in the Hamilton area, Atco area, all up there where there's our farming communities. These immigrants that come up and they work for the summer, they need clean housing. They need access to facilities to go to the bathroom, to clean up. It's very, very important. Sanitation is very, very important in that respect. Civic involvement. Lobbying elected representatives for a ban on e-cigarettes and adolescents. I do not even want to go down this road with you because this is something that is very, very near and dear to my heart. And if I'm going to go down that road, then we're never going to get through the rest of this PowerPoint. But if I was concerned about that, and I am, I would contact my representatives so that to make sure, or to try and ensure, that these e-cigarettes and those tobacco products were not sold to adolescents. So secondary. Secondary. When we're talking about secondary interventions, we are talking about screening. Secondary, screening, secondary, screening, secondary, screening. They're both S's, just like primary with prevention, they are both P's. Secondary with screening, they are both S's. And the aim to reduce the impact of the disease process by early detection and treatment. We are going to screen. We are going to screen for the disease process so that we can detect it earlier and we can implement treatment sooner so that your client can get well. For example, a community health nurse may screen a sexually active adolescent girl for hepatitis B and or HPV. And she has known risk factors for sexually transmitted infection, but as yet, she has no apparent disease symptoms, so she's at risk. So the nurse will teach her how to protect herself from further STIs, hepatitis B, and HIV in the future. So other examples of secondary interventions include providing outreach screening programs, offering mammography, scoliosis screening, lipid testing, prostate-specific antigen testing for prostate cancer. All of this is an example of screening, secondary intervention. Tertiary. The goal of tertiary, which is a third-level intervention, is to halt the disease progression and or restore client functioning to the pre-disease state. Tertiary. I am doing something to halt the disease progression. I am treating you. Tertiary. Treatment. Tertiary. Treatment. Tertiary. Treatment. The same way primary is for prevention. They are both P's. Secondary. Screening. They are both S's. Tertiary. Treatment. They are both T's. So the nurse is required to collaborate with members of other healthcare providers to provide treatment. For example, a student may report to a school nurse that she has been involved in unprotected sexual activities. So, the school nurse may refer the student to the public health clinic for a pelvic exam and lab testing to detect whether or not she has an STI. We're going to look at hepatitis B, we're going to look at HPV, and we're going to look at some HIV screening. The student has an abnormal pap smear that is now suggestive of HPV exposure. So the clinic nurse, in collaboration with the provider, there's that term again, collaboration, will administer any required medical treatment. So, this child, this young adult has come to me, I've evaluated her, I've assessed her, I'm collaborating with the clinic to do the screening, and so now those test results are back, and I am going to implement my interventions, which is my treatment, my tertiary prevention. As there is no cure for HPV, the teen also needs to learn how to prevent the spread of the disease to others and obtain regular Pap and pelvic exams to detect cervical cancer and then other possible STIs. So she also needs education on how to not only protect herself moving forward, but also to protect her sexual partners. So let's talk about career opportunities for community-based nurses. What can we do in the community besides be, a nurse that will go into someone's home, or a nurse that is a public health nurse and I'm going to work for the county and the government? Well, there's school nursing. So nursing practice in the school setting became when educators realized that children with health problems had more difficulty learning. And this just makes sense, right? If the child does not feel well, if the child has attention deficit, if the child is a diabetic, if the child is an asthmatic, if there's a medical issue going on, and if that is left untreated during the many, many hours that ordinarily they would be at school, not in this age of COVID, but that they would ordinarily be in school, then we need to have a healthcare professional that is able to assess these children and then to implement a treatment. So the core focus is keeping students healthy and in school, as school attendance is essential for academic success, right? Because the children can't learn if they're not in school to learn. The same way, we are hopeful that we would be with you in order to impart all of this information, but I assure you that I am doing the best that I can. So, school nursing will provide direct care for children with chronic health conditions such as asthma, attention deficit disorder, and diabetes. She will help children who need routine procedures such as a neb treatment or a blood sugar check. She can do vision and hearing screenings, and she can also ensure that age-appropriate immunizations are documented and up to date. She may offer health education on topics such as nutrition, physical activity, and sexual and reproductive health. And she can offer this education not only to the students, but she can offer this education to the other faculty members that she's working with and parents as well. She can serve as a role model for students who lack parental support or who are struggling with peer pressure. So she is also going to be a resource. So the school nurse is autonomous, and she must be capable of prioritizing and making decisions. Occupational health. Occupational health nurses work primarily in industrial or in corporate settings, and they provide health promotion programs for employees and their families in an effort to reduce absentee hours, increase productivity, and reduce illness and complications, right? Because the employee is no good to the employer if they're not there to work. So by providing these health promotion programs or by having access to this nurse, then if there's an issue, the nurse can follow the patient, follow the client, follow the employee to say, are you doing your blood sugar checks? Are you using your nebulizer at home? Do you have your inhaler with you? Because we want them to be able to be at work and to be productive while they're at work, right? Because that's what's going to make the employer happy. Complete required medical documentation for disability claims or occupational hazard events, and to conduct new hire and annual screenings. She can also provide care to injured or ill workers. If necessary, she can obtain random drug testing, and she can also help to file workers' compensation claims. So, parish nursing. Parish nursing is a specialized area of the nursing practice that focuses on the promotion of health within the context of the values, beliefs, and practices of a faith community. So she can act as a health educator and a personal health counselor. Again, we are counseling and educating, increasing awareness of the interpersonal relationship between lifestyle, personal habits, attitudes, and spiritual beliefs. And are you doing something? Is there a habit that you're indulging in that is in conflict with maybe a spiritual belief, and somehow it is putting you at risk for becoming ill? She can also develop support groups, she can train volunteers, and she can provide community referrals as needed. So she is more of an educator and a counselor, and someone that will just listen and guide you and refer you to someone else for actual treatment. Nursing in correctional facilities. So corrections nurses deliver health care within the criminal justice system, for example, in juvenile detention, in a substance abuse treatment facility, and a prison. She may provide primary care services to people of all ages. She needs to be unbiased and non-judgmental. She may also perform occupational health duties for facility staff. So for personal safety, these nurses must meet certain physical requirements, complete special weapons training before working in most correctional facilities, and that is why I am not a correctional nurse. And in this field, there is a high level of autonomy because you are essentially working alone, and you are also involved in policy decisions involving inmate health care, because you will be the person who documents you will be the tracker. If there is an exacerbation of some sort, you're going to be the tracker. So if there's something going on within the prison community or the jail community, you are the person that they're going to go to, and they're also going to go to you and say, well, how do we fix this? So public health clinics. Many community nurses practice within local and state departments of health, including public health clinics. Large cities tend to have nurses who will specialize in immunizations, prenatal health, school health. But as I said before, smaller communities may have fewer nurses providing broader services. Disaster services nursing, an area that I've always wanted to look into but never quite had the time. So a disaster is any event or catastrophe inflicting widespread loss of life, diminished health, destruction of property. So her duties may include rapidly assessing the overall situation and that of individual victims. So this is the nurse that is going to be assessing whatever disaster has just occurred. Fire, explosion, multi-car accident. She is going to assess the overall situation, and then she's going to look at the individuals, and then she will begin triaging care and initiating life-saving measures first. She will adapt nursing skills to the disaster situation, considering available equipment, supplies, and personnel. She will evaluate the safety of the environment, and she will make sure that health hazards have been removed. So not only do the people that I'm working with have to be safe, but my patients, the patients that I'm dealing with, the population that I'm dealing with, they also need to be safe. She will provide leadership in coordinating care, assigning priorities for care, and transporting victims. She will prevent further injury or illness. So I am going to treat you so that you can begin to get well, get better. And she will provide compassionate support to victims and their families. Culturally competent care. Now, culturally competent care is something that was talked about in semester number 1, maybe. So I am not going to go into a lot of this in great detail, but I just want to review it because it is so, so important when you are in the community, when you are going into people's homes. You need to have some sort of respect for their culture and their beliefs. So the terms cultural awareness, cultural sensitivity, and cultural competence are often used interchangeably. However, they are not the same. They are not the same. Cultural awareness will refer to an appreciation of the external signs of diversity. Meaning, yes, I appreciate the fact and I acknowledge the fact that we are not of the same culture. Cultural sensitivity. Listen up, listen up, listen up. Cultural sensitivity has more to do with personal attitudes and being careful not to say or do something that might be offensive to someone of a different culture. You need to be sensitive to their culture. You need to be sensitive to their beliefs. You need to be sensitive to their customs. And then cultural competence is achieved on a continuum ranging from incompetent to competent. So again, just as a review, the Purnell model for cultural competence stresses teamwork in providing culturally sensitive and competent care to improve outcomes for individuals, families, and communities. And so if you have access to your trees book, you can look on page 322 and you can review the Purnell model. If not, Purnell's model will define cultural competence as adapting care to be congruent with the patient's culture, meaning that what I do, my treatment plan, how I treat you, has to be congruent to your culture. I need to respect your culture. The model will identify several levels of cultural competence. For example, unconscious incompetence is not being aware that you lack knowledge about another culture. So, I don't know, does this mean that you're adult? That I have no idea that there are people out there that do not believe as I believe, or we do not live in the same culture. Conscious incompetence is being aware that you lack knowledge about another culture. So this is saying, I acknowledge that we are different. I acknowledge that you are of a different culture than I am, but I have no knowledge whatsoever about your culture. Conscious competence. Listen up, listen up, listen up. Conscious competence is learning about the client's culture and providing culture-specific interventions. This means that before I try my treatment plan, before I come to your home, before I try and treat you, before I try and educate you, maybe even before I come into your home and assess you, I need to learn about your culture and learn about how to approach you so that I can treat you respectfully for your culture and in your home. And unconscious competence is automatically providing cultural congruent care to clients of diverse cultures. So, as always, there are barriers to this care. So barriers to culturally competent care. One is bias, and this is a lack of impartiality, and this can be positive or negative. I can be biased. I can be unbiased. Sometimes being biased can be a very positive thing. Ethnocentrism is the tendency of people to believe their own beliefs and values are right and those of other cultures are wrong. This means that whatever I do, whatever I say, it's always going to be my way, and I am correct, and whatever your culture believes or whatever your belief system is wrong because you do not agree to what I believe. Cultural stereotype is the unsubstantiated belief that all people of a certain racial or ethnic group are alike in certain respects, and this can also be positive or negative. And I believe another word for this may be profiling, I think. So, prejudice. Prejudice is when negative attitudes toward people are based on faulty and rigid stereotypes about race, gender, sexual orientation, and status. That is prejudice. Discrimination. Discrimination is the behavioral manifestations of a prejudice. For example, refusing to provide services or opportunities to certain racial or ethnic groups, and that is discrimination. So, racism. We're going to take a look at all of these. So, racism. Racism is a form of prejudice and discrimination based on the belief that race is the principal determining factor of human traits and capabilities. Racial differences may produce an inherent superiority, and especially now in these times, racism may provoke very, very powerful emotional responses. Sexism. Sexism is the assumption that members of one sex are superior to those of the other sex. Males being superior to females, for example. And then male chauvinism, which is the assumption of male superiority. So male chauvinism is common in many cultures, and it may be overt or subtle, such as the man is the head of the household. What the man says, what the man does, the decision that the man makes is final, and that is how they run their home. Language barriers. Language barriers happen all over. More than 60 million people in the United States speak a language other than English at home. These language barriers will affect your ability to communicate with your clients. Street talk, jargon, slang. These vocabularies can sometimes be very, very challenging, especially healthcare jargon, our terminology, and our abbreviations. Clients may not understand them. So we need to speak in more simplistic terms so that we are understood when we are talking. So, hospice nurses. Let's talk about hospice nursing. Hospice nurses focus on care of patients who are dying or whose condition is not expected to improve. Hospice is different from palliative care. Hospice is looking at patients who, again, their condition is not expected to improve, and sooner or later, they are going to pass away. I think before the guideline to be on hospice used to be 6 months. I'm not exactly sure if that is still the guideline. So if the expectation is that the client will pass away in 6 months, then they will be referred to hospice. But then again, we don't know. We don't know. Someone who may have a life expectancy of 6 months can pass away in a week. I have taken care of clients at home who have been on hospice, and I have actually had to either discharge from hospice because they did not pass away in that 6 months time frame. So I either had to transfer them to palliative care, because now they have somewhat learned to live with their condition, with their disease process, or to discharge them totally from home care. So hospice services are provided in the patient's home, also in the hospital, in nursing homes, and in homes specifically designed for end-of-life care. And these are called hospice homes. I do not know, I don't think that there are any in the state of New Jersey. It would be nice if there were. So the goal of hospice care is to promote comfort and quality of life throughout their illness until they pass. Focus is on providing comfort and managing their symptoms. And as a direct care provider, the hospice nurse will assess the client's condition and monitors responses to interventions aimed at relieving distress. So again, we are assessing. We are going to evaluate the interventions that we are doing to eliminate or relieve their distress, to make them comfortable. So again, the nursing process does not go away simply because you are not in the hospital setting. As an educator, the hospice nurse will teach the client and the family how to adjust medications and care to control pain and whatever symptoms they may also be having. The roles of communicator and client advocate assume prime importance. So again, at the very, very beginning of this lecture, of this PowerPoint, when we were talking about the roles of the community nurse, we talked about these roles: communicator, client advocate. In terms of hospice nursing, the role of communicator and client advocate assume prime importance. Future of home care, because we know that home care is growing, right? Healthcare analysts have predicted several changes in home care during the next few decades, and this is because increased need for home health care. It is most cost effective to provide health care in the home than in the inpatient setting. It is cheaper. It's cheaper for the insurance companies. And truth be told, patients in the hospital will get to a certain point and they'll say, you know what, I can do this at home. If I'm just getting out of bed, sitting in a chair for a period of time, and then I'm going to go for a walk in the hallway, and I just have to check my blood sugar and make sure it stays within a normal range, I can do this at home. So in which case the healthcare provider, the physician, will discharge the patient home, and then they will employ a home care agency. Increased use of the home for hospice care. Public acceptance of the home as a place of comfort and care, as well as the cost of inpatient care, has increased the number of persons who choose this compassionate option for end-of-life care. So these are patients who are in the hospital, and they know that they're not going to get well. They know that their condition is not going to improve. They've been admitted to hospice care, and they're like, you know what, I don't want to die in the hospital. I want to go home. I want to die in my home. I want to die with my family around me. I want to die in my own bed. So we send them home, and we employ hospice. Increased technology. Technological advances such as online resources or telemedicine make it safer and more affordable to deliver complex care in the home and allow home health nurses to deliver information and to provide support. And research. Home care has an awful lot to do with continued research. So the home healthcare nurse, I have done home care now for quite a few years. I did not do it this past summer though, as I have many, many family members that have comorbidities, and they are considered at risk as far as COVID is concerned. So I did not work in the community this past summer, and I did miss it. So in the day of a home care nurse, how your day goes will vary, but it is the same as in the hospital setting. You come, you get report, and you think that your day is going to go one way, and then one of your patients goes south, or you have a lot of discharges, or anything can happen. We need to be flexible in home care, in nursing in general. So the day of a home care nurse will vary. Most agencies like your caseload to be contained within a limited geographic boundary. This is to enable you to be more efficient, to spend more time in the home with the client, doing what is important, rather than driving from Atlantic City to Estelle Manor. Not to say that there have not been days where I have seen clients in Atlantic City, and by the end of the day, I did end up in Estelle Manor, but that is hopefully not the norm of your day. So the objective of a home healthcare nurse, listen up, listen up, listen up. The objective is to develop a rapport with the client and the family to establish trust. And this can be done within the initial moments of that home care visit. How you approach the family, being culturally competent, respecting their boundaries, respecting their home, letting them know that you are there to care for their family member, and also take into account whatever needs the family has. This is a way to establish rapport and establish that trust. And this can be done, I promise you, within those first valuable few minutes that you are in the home. However, we need to be safe about this, right? Because reality states that we are sometimes going to go places that we may not feel comfortable. That's all I'm going to say about that. So, before the visit, if you are making a home visit, before the visit, you are going to look at the client's chart. You're going to look at the referral form. Why are you going? What is the purpose of this visit? Why are you going there? So you're going to look at the client's health problem. You're going to look at the medications. You're going to look at the treatment plan. And then you're going to say, okay, I'm going to go out there. I'm going to review their medications. And I'm going to educate them on a blood pressure medication. And I'm going to educate them on the fact that they need to follow a low-salt diet to help keep their blood pressure in a safe range as they continue to take their medication. That is the reason for the visit. That is my treatment plan. Then what do I need? What supplies do I need? Do I need educational supplies? Maybe I'm going to go out and do a dressing change. I'm going to assess the wounds and I'm going to do a dressing change. Do I have everything that I need to take with me? Because it's not like the hospital setting. In the hospital setting, if you're in the room and you decide you need more 4x4s or some cling, you didn't bring in enough tape, you need another pair of gloves, you can just put the light on. Or you can stick your head out the door and you can say to somebody who's in the hallway, hey, listen, can you just go to the supply room and can you get me some more supplies? In home care, that is not the case. You have to remember to try and bring all of those supplies and then some with you when you go to the home. So you're going to review the teaching materials, establish the goal for the visit, dressing change, education, assess pain management. You're going to prepare your supplies. You're going to make a plan. I'm going to think about everything that I'm going to potentially need. I'm going to prepare everything. I am going to make sure that my bag is stocked with the supplies that I need to meet the needs of your client. But not only this client, however many clients I am going to be seeing throughout the day. And I am going to do everything I can to make sure that I am safe while I am doing this visit. So in order to provide for my personal safety, I'm going to let my manager, my case manager, know where I'm going on my route and the time that I am doing my visits. So I'm going to let them know that I am going to be in Atlantic City by 9 o'clock, and by 10 o'clock or 10:15 at the latest, I expect to be seeing the client that I have in Margate, so that at 10:15 When that client calls and says, the nurse said that she was going to be here at 10:15 and she's not here yet, and believe me, I promise you, if you tell somebody that you're going to be there at 10:15, it's 10:16 and they're calling and they're saying, where are you? So at least the home health agency will know where you have been, so they know how to find you. They know where to look for you. In doing a visit, and this could be a visit anywhere, not necessarily Atlantic City. I have done visits in Atlantic City that have been wonderful, absolutely wonderful. And then I've gone to a visit in Northfield, and it's, oh my God, what the hell am I doing here? And not only am I not safe, but this patient is not safe in this home. So once you get to your destination, once you get to your site where you are going to see your client, if you feel unsafe, if you feel that going into the home or into the building is going to put you in an unsafe situation, you do not go in. You will call your case manager, you will call the home health agency that you are working for, and you are going to report that. And should you decide, I'm feeling a little uneasy, but I think I may be okay, you are not only going to carry your personal cell phone, but most home care agency will give you your a work phone, or a secondary work phone. And so you are also going to carry that cell phone with you. So medication management is a huge initiative in home care. One of the Joint Commission 2016 safety goals for home care is to use medication safely. Now, in a hospital setting, the nursing staff there is supposed to be beginning the process of medication education and medication management. But we know that they're very busy, and we know that this may not be high on their list of priorities. So this is something that we need to look at very, very seriously in the home, because home care is very different than hospital care. In a hospital, yes, they are at risk to fall. They are. But where are they at risk to fall? They're at risk to fall between their bed and maybe the bathroom, their bed and the commode. They're not going to be wandering in the halls and falling. However, you have someone at home, they are at risk to fall all over the home. They're at risk to fall in the bathroom. They're at risk to fall in their bedroom. They're at risk to fall going in and out of their home, outside if there are steps. They are at risk to fall in the kitchen. So we need to look at their medications and make sure that they are taking them safely, especially if they are at risk to fall. So this would include preventing errors with look-alike and sound-alike medications, educating patients who are on anticoagulants, who are on blood thinners, keeping a list and reconciling medications when a client transfers from one agency to another. Now, when I say one agency to another, I also mean from the hospital setting to a home care agency. Because the hospitals, the medications that they're taking in the hospital may not be the same medications that they're taking at home. Or they may be taking the medication in the hospital. The hospital nurse may be referring to it as a generic. They are going to go home and they're saying, okay, I have to take this medication. I have to take in the hospital, I was taking hydromorphone for my pain. But at home, I'm taking the hydromorphone and I'm also taking Dilaudid. They may not understand that that is the same medication. So they may say, okay, well, I have to take my hydromorphone at 8 o'clock in the morning, and I have to take my Dilaudid every 6 hours. Well, I'm taking my hydromorphone, and now I'm double dosing myself because I'm also taking my Dilaudid. So we need to reconcile those medications so that they are taking them safely. And so also they may have been coming from one home care agency and then transferring to another. So again, we need to reconcile those medications. Older adults. When we're dealing with older adults, we need to involve family members in the care of the older adult including these medications, including medication management, including medication education. Older adults and caregivers may have difficulty remembering when to take their pills, which ones to take, and even whether they have already taken them. I can't remember. I don't know. There's too many medication bottles here. There's too many containers. So, we can provide them with a medication organizer. So the nurse may suggest a medication organizer with a compartment for each day of the week. And then there are some that have days of the week, morning, afternoon, evening meds. The nurse may need to prepare a week's worth of oral medications for them during a visit. So I'm going to fill the organizer with all of their medications. I'm going to tell them what they are, when they're to take them. And so I can also set reminders. I can put a reminder on the refrigerator. Some organizers are very fancy and they have timers on them. So the timer's going to go off and they can say, oh, it's time for my medication. So I am preparing a week's worth of medications, but I am not exactly sure if my client understands or if the family understands when they should be taking these medications and how often. So even though I'm preparing a week, the nurse may need to return in a day or two to evaluate whether or not the patient or the family or both are being compliant with the medication regimen. You understand? So even though, listen up and pay attention. Even though I am preparing a week, if I am not confident as the nurse that this family is going to medicate this patient or this client can take their own medications, I may need to return in a day or two to make sure that they are taking these medications as directed. I'm not going to wait a whole week. Because then if I come back in a week and I'm looking at the organizer, I have no idea what the heck is going on. But if I come back in a day or two, I can have a better handle on whether or not they are being compliant. So, the home care goal. Listen up, listen up, listen up. The home care goal. The home care nurse is focused on an individual patient, and the primary goal is to have the patient function as well as possible. That is the goal of home care. So, there is something that I want to say. I meant to include this at the beginning of the lecture, but I was a little distracted at the time. So, there have been many emails already. There has been much discussion, I know, among you and believe me when I tell you, among faculty about the best way to approach this. And yes, we have been given freedom to approach lectures and do whatever we need to do, or whatever we feel is best, I guess I should say, in order to get this information across to you. So, with my lectures, in relation to my lectures, there will be a pre-assignment. You will have had this pre-assignment whether or not we were remote or not. This is an assignment that you would have had to do if we were face-to-face. This is only to give you an idea of what I'm going to be talking about when I come to lectures, so that if you haven't done any readings, at least if you have done the pre-assignment, you have some idea of what I'm going to be talking about. I am pre-recording the lectures, and then I am also including a clean PowerPoint, because last semester some students wanted a clean PowerPoint that they were able to print out and make notes, I guess, while they're listening to the lecture. You can listen to the lecture as often as you wish. You can listen to it at 7 o'clock at night. You can listen to it at 7 o'clock in the morning. If you want to listen to me more than once, you are free to listen to me more than once. Why anybody would want to do that, I have no idea, but you are free to do that. There will be a class activity that will be done during our regular class time. Now, The question was posed. If we are taught in real time, we have the opportunity to ask questions and for discussion. This is my thought. I am giving you all of my information right now. I am giving you my lecture. I am giving you the PowerPoint. Whatever I would have said had I been in front of you, you have gotten all of that information right now. You are free to make notes about something that you are not clear on. You are free to note questions, something you want to discuss further, if there's something that you are not clear on. If you don't want to wait until class time, you can send me an email and I will be more than happy. If you want to request an appointment, I am happy to see you on Collaborate. If you feel as though a phone call is better, I can give you my contact information and we can talk via phone. During class time, regular class time, we will be doing class activities. We can discuss anything that you are not clear on. And then, after the class time, there is going to be a post-class assessment, a very short assessment. You can use it as a review. If you want to, you can use it as a study guide for the exam. All it is going to do is review the information that I have already presented to you that we may have discussed in class time. Before the exam, I will be posting times when I will do a Q&A. So if you still have questions, if you still have material that you are not clear on, we can meet on Collaborate during this Q&A and you can ask those questions. We can have that discussion. I am happy to clarify. So by the time you sit down for that exam, as far as my information is concerned, you should have been saturated with that information. If you are not, if you still have questions, comments, concerns, please reach out. I am here and I am waiting for you to simply reach out and ask me your question. Let me clarify the information for you. So with that being said, I will end this. I am recording just after or just during the holiday weekend, so I hope everyone was safe. I hope everybody was able to relax and enjoy the weekend and enjoy the sunshine. And again, if there are questions, comments, concerns, please feel free to reach out. See you later, guys.